So I'll be presenting on acute ischemic findings. So we'll start off with a case. So we have a 55-year-old male who's coming in with sudden onset of severe chest pain. He's clenching his chest. He said that he was walking his dog an hour prior to arrival when he started having the onset of pain. And on exam, he appears diaphoretic and very uncomfortable. And his vitals, he's normotensive. He has a normal weight at 70. He's mildly tachypnic, statin great, and he's afebrile. So this is his EKG. So first question we ask, right? STEMI or not STEMI, like activation or not. So would you activate this patient based on STEMI criteria? So I wouldn't, right? Because I don't see, so I see a lot of ischemic changes, but I don't see ST elevations. I would do serial EKGs though. So if the patient's having active chest pain, I would definitely get the patient in the room, do all your chest pain workup and think about all these differentials when it comes to ischemic findings on EKG, and one being ACS. And then I would do serial EKGs like every, like if possible, every 10 or 15 minutes to see if there's any changes. So these are the questions that we have to think about, right? When a patient comes in, what's the etiology of the chest pain? There's life-threatening in the ED. We worry about all the life-threatening chest pains and try to rule it out. And then after that, if we're like, no, they don't have ACS, they don't have a PE, they don't have a pneumothorax, anything that would harm the patient or cause them to decompensate really quickly, we basically have a little checkbox, right? So ACS is with his symptoms. He had symptoms on exertion or activity, and he appears diaphoretic and very uncomfortable on exam. So my suspicion for ACS for him is really high, and he has risk factors. So then that's one of our questions, right, is ACS. And then some of the POCUS questions that we're going to be learning today is evaluating for regional wall motion abnormality, how to describe the abnormal wall motions, right? Because a lot of times when you see something, it's not really squeezing simultaneously with the other walls, then we have to learn how to describe it, especially to our colleagues, our attending, our consultants. And then finally, we'll determine basically the territory of where the ischemia is based on their coronary artery distribution. So real quick on the exam, since we have new learners in the conference, we start with a phase arrays probe, and then we go in our short axis view. So where your cursor, your marker is basically pointed to the left, patient's left shoulder, and this is on cardiac mode. And then you get basically a personal short. So it looks like this. We'll go over different levels, but basically you want to be at the level where the papillary muscles are. So it allows for the best visualization of all the different walls. So seeing the papillary muscles, I don't know if you can see my cursor, but you basically right where you kind of see those two muscles that kind of, they're almost like a mirror image of one another. So that's where you want to be when you're taking a look to see if they, if you're concerned about any wall motion abnormalities. And so next, we're gonna answer one of the questions, like what is considered regional wall motion abnormality, right? You got normal, you have different ways to describe it. So you have hypokinetic. So hypokinetic basically means that there is a decrease in wall thickening and the endocardial excursion, versus if you're comparing it to akinetic, you have basically no wall thickening at all, or endocardial exertion at all. So it's not moving versus this is moving poorly. And then you're also contrasting it with dyskinesia. So dyskinesia is different. So it's this paradoxal systolic outward. So this wall, so when all the other walls are contracting inwards, this is actually a systolic outward motion, or stretching or thinning. I don't actually see that as often, but it's good to kind of know the different descriptions of how to of your wall motion abnormality. And then there's one I'll have a video of it later, but there's aneurysmal as well. So the aneurysmal is basically a bulge that eccentrically, you'll see like an eccentric bulge during systole as well as diastole. So this is a kind of global image or video of hypokinesis, right? So then you have pore squeeze of this wall versus akinetic, which is hardly even moving, and dyskinesia, right? Dyskinesia right here, where you can see this is moving in and that's actually moving out. So you have like that outward contraction, or not contraction, but movement. All right, so let's go over some videos. These are some examples. So if you want to just say, not all at once, but what you think the wall motion abnormality is here.
So
Andrea, do you want to take, oh, I was like, I was going to give an opportunity to Andrea. Andrea, do you want to take a guess at it?
Why don't you tell her which walls we're looking at first?
Okay. Oh yeah. So so basically you'll see this is the left ventricle. And what we see is you're actually looking at the right ventricle here. So you actually, based on the exertion of the right ventricle, you break down the walls at the papillary muscles, and we'll see that a little bit later. But basically you'll have anterior, so this is your anterior wall here. So like it's like a half circle, a semicircle here. So for wherever the RV is here, that kind of show that just kind of shows you where you would draw like a semicircle. So you have anterior wall, and then you have inferior wall, and from there you actually subcategorize it to septum and then lateral wall. So then you have anterior septum, anterior lateral, and then you'll have inferior septum and then inferior lateral. And then yeah, go ahead.
No, sorry, go ahead. Go ahead.
I was going to say, if you're having a hard time kind of seeing if they all move in towards the center, basically they have to kind of, the walls kind of come into the center. That's your hint of whether if there's any abnormality. So here, if you were to put like your finger in the center of the lumen, then you can say like, well, let me see what walls go in as well. So here you can say that basically your inferior wall looks okay, that it's actually going towards the center of the cursor. And then you have your lateral, it's basically your lateral wall here goes into the center. And then your septal wall,
I feel like the septal wall is not moving as well.
Right. So then you can break it down. So you're like, is it inferior or anterior? So you take a look at this wall and you're like, well, it's moving more than that, right? So to me, this seems it's anterior septal. That could be, right, it's hypokinetic. So you would say it's anterior septal hypokinesis here.
Good explanation. Thank you.
Yeah. And then another example here. So again, right ventricle, this insertion point's over here. It's a little harder to see. And here, you cut it right, you kind of slice it right in half. And then you take a look and you're like, okay, well, this is anterior wall. This is inferior wall. And then break it down even further, septal, and then lateral. So then you're like, okay, so which one is moving okay?
So I think once again, it looks kind of like septal wall is not moving as well here. more, I guess, anteriorly.
Yep. So
Or
same
not
thing.
well? Yeah. Okay, same.
Yeah. So then here you're like anterior and septal. So then this is your kind of like your 1/4 of the pie.
Mhm.
Natalie, what do you think about the inferoceptal wall in that view? Because it looks like the inferoceptal wall really wasn't thickening either.
Oh,
This,
hold on.
sorry, this the one that you had. This,
I think that was a repeat actually. This one?
yeah,
So this right here,
yeah,
the wall,
right.
right?
Yep,
Yeah,
yep.
it's I don't think it's I see
Not thickening.
decreased wall thickening. So I would say that fits in the definition of hypokinesis
Right, right. The
rather
whole.
than,
Yep.
and then this is another one. So again, insertion point of RV is here, RV is here. And then you just have to kind of train your eye, just trying to see, kind of put your finger in the center and be like, okay, which walls move in towards the center better than the other walls. And then you're basically looking at the muscles here. So, and then in this case, I would say this is anterior, this is inferior, lateral, septal, and basically the anterior wall is actually moving well, not so much the inferior wall. Do you guys see that? Take a look at this side, like the muscles are not moving, contracting inwards as well as the anterior one. Okay, and then going another example here. So this is different, right? So how would I describe this wall? And again, this is right ventricles over here. So this is the insertion point inferiorly, and I would say like anteriorly it's around here. So then again, cut it in half, anterior, inferior, lateral, septal. And then inferior wall is moving good, even lateral. But then look at this wall right here. Is it moving at all? Is it hypokinetic or akinetic? To me, that appears more akinetic because I hardly see even any contraction. And then this was also an apical 4 chamber view. And you kind of take a look. And also the distribution here is you'll have septum here and lateral wall here. So kind of, and to confirm your suspicion, you can always do it in 2 views, right? So short axis, and then you can actually turn it 4 chamber and then see more of the walls there. Right here, the septum's not even contracting. All right, so I think this is probably one of the last examples before we get to more of the educational things here. So this you can tell. What do you think about this one? So you have RV to compare, right? And then this is LV. Right, so this is definitely akinetic and it's global akinesis. Right. Okay. Here, another example. I would say seems like maybe anterolateral or inferior lateral. I'm sorry, inferior lateral. Not really moving as well here because then the insertion points are here. So then it's cutting it in half here. So your inferior lateral wall is over here. So that's not moving or at least squeezing inwards. Okay. And then that's a parasternal long view. So you'll see some element of diastolic dysfunction there too. Okay, so some pearls of getting basically the echo view, the when you're actually checking for ischemic findings, it's always helpful when you actually have a prior echo to compare it to. So images, whether it's through ACPA or you're able to view images from an official echo, like a comprehensive echo that they do in the lab, to see if they've had old changes before. And then also use your ultrasound in conjunction to everything else. So history, exam, and EKG. And it's always good to have serial EKGs and echoes, especially if the patient continues to have chest pain. All right. So now we're going to go over basically the distribution of the coronary arteries and the walls. Basically, the LV segment correlates with each coronary artery perfusion territory. So here, what we do is you're at the peristernal short view, and what you're going to do is basically slide down the chest. And based on how the orientation of the heart is. So you're here, we're going to go basal, mid, and apex. So they created a 17 segment model to basically break down the territory of the coronary arteries. And we'll go through the first cross section first. So here you have the base where you're at the level, you'll see the mitral, valves at the base. And basically it's broken down into 6 segments, the base, and you'll see the distribution of the coronary artery here. So then you'll see if you were to cut this in half where you have the insertion point of the RV, you'll have, this is anterior, which is, this whole section is anterior. And you'll see with the green, it's LAD here, right? Because LAD basically supply the septal wall as well as anteriorly. And then here you'll have also circumflex and LAD. And then if you were to break down inferiorly, this is the inferior wall. So most of it is supplied by the RCA and the circumflex here. And then if you're actually at the 4 chamber, you'll see septum as well as lateral wall. And then you'll see mainly RCA and LAD here, because LAD is apex here, and this is more of the anterior septum. And then here, most of your lateral wall is anterior lateral wall is the circumflex and LAD. Going down to the mid level where the papillary muscles are, you'll see also split into 6 segments. And you'll see, like not so much difference, right? So then you'll see like here it's LAD, circumflex. And then here it's LAD and then RCA. And then here you have a little bit of circumflex and RCA here. And then with the 2 chamber though, you'll notice that it's circumflex is not here. So you have mainly RCA as well as, and then you'll have LAD for the lateral wall. Going down to the apex, you'll see more so. This is actually broken down to 4 segments. So you got 6 segments, 6 and 4. So here you have majority is LAD, right? So majority of LAD, a little bit circumflex here with LAD laterally, and then fairly you have LAD and RCA. And then same thing with the long axis. You'll have LAD for the lateral wall, and then for the septum, you actually have, or the posterior, this is the posterior wall, this is the septum. So you have circumflex and RCA and circumflex there. This is the posterior wall. So when you get like posterior ischemia. And then, so it's 17 segments. So the other segment is just basically a cross section of the apex, which is basically LAD. Okay. So I have a couple questions here for you. So 70-year-old female with history of diabetes and hypertension presents to the ER with acute shortness of breath and chest discomfort. Which of the following echo views would be the most helpful in evaluating distribution of all three major coronary arteries in a single view?
Come on, rotators.
So I guess we just talked about peristernal short access with mid-papillary view.
Yes.
And then the Sal-P trick that Dr. Kalama taught us, or
Yes.
taught me, and I think she just put it in the chat as well.
I saw that. Yep. All right, next one. So this is more a live video. So which coronary artery is affected by this regional wall motion abnormality? So again, you'll see, I don't have really the RV here, but you can just imagine it's probably, see how the paradigm is here and then here. So then you can just kind of cut it down the center here. So anterior, inferior wall, lateral, and then septal. So where, first of all, your question is, where is the regional wall abnormality? And then second, then you say, okay, what is the distributing coronary artery?
So this one I have more trouble telling where the wall motion abnormality is.
Okay, so we can break it down, right? So then you can just basically imagine half. Can you see my cursor, by the way?
Yeah, I can.
Okay, so cut it in this basically a half semicircle here. Okay, and then just take each wall at a time. So look at the inferior wall first, moving inwards.
I think inferior looks okay.
Okay, now like take a look at the upper portion. How about your anterior?
Yeah.
Is it
a little less on the anterior?
well?
Yeah, a little less on the anterior.
Yeah. So from there,
so if it's anterior, that would be
now you look
LAD?
at walls. Yes. And then do you know which walls? Is it the entire anterior wall you think is not moving well? So when you look at lateral and septal, you basically
I'd say I think more septal.
Yep. So that's how I see it. So if you ever get lost and you're like, I can't tell, just break down the segments, and that way you can say anterior, inferior. Do I see a difference in how it's squeezing inwards towards the center? And you did it, right? And then break it down even further in the subcategories like septal and inferior. Like, are they moving concentrically together? Okay, so yeah, LAD. All right, next. Which complication of acute MI is demonstrated here? So do we see a cardiotamponade or fusion, pericard fusion?
I do not see one.
Okay.
I don't see one.
There's a little bit.
Up here. Yeah, that's true. I was looking below.
The answer is tamponade. Do you see tamponade? So I don't see tamponade, right? So the next papillary muscle rupture, you're like, okay, well, I get this view. If there's a papillary muscle rupture, what would I see? You know, basically they would have acute mitral regurg, but do I see color Doppler here?
Yeah, you need color for that to evaluate.
Like, no. And then process elimination, mitral regurg is the next one. And then you're like, okay, do I see VSD? No, well, I can't tell, right? Because if they don't put Doppler through here. So then by process elimination, it's pseudoaneurysm. And then this is what the aneurysmal movement or example was that I wanted to show you before. So in addition to hypokinesis, dikinesis, as well as dyskinesis, and as well as akinetic, this is the aneurysmal. So you almost see like a bulging out. Moment. Okay. So what are the limitations of basically?
Just like a little clarification, it's specifically like a diastolic bulging. So you'll see the bulging in diastole. So when you're see how like it kind of balloons out like that.
Can I do it in slow motion?
So valves open, huge chambers pouching out.
I'm gonna close. There, it's closed.
Huge.
All right, what are the limitations of basically trying to find ischemia on ultrasound? Basically, if you have inadequate cardiography, right? We've all dealt with this where it's the patient's anatomy, their body habitus, the positioning. So even having them lay on their left lateral decubitus will help us because it brings the heart closer to chest wall. If they have chronic pulmonary disease like COPD or asthma, it hyperinflates their chest walls. So it's harder to actually see the heart in those situations. And then also, obviously operator dependent. So like if you're off axis, right? So making sure you have your landmarks are important. And also if they actually have a pre-existing ischemia. So for example, if they have a prior MI or an NSTEMI, if they have a focal myocarditis, they have a left bundle branch block, right? Because that would cause decreased movement of into their septum, or even into their other walls as well. Stress cardiomyopathy, right? Takotsubo will be able to see the apical ballooning, aneurysm. And then if they've had prior cardiac surgery, so like valve replacement, that can also won't be as obvious in terms of finding ischemia on your echo. Okay, so when I researched a few articles. One of the articles from the American Society of Echo, basically, they were just saying how, in a couple resources, chest pain or echo findings like regional wall motion abnormality was one of the earliest clinical findings, even before chest pain and EKG. But they also mentioned that you actually see diastolic dysfunction, which is like Afzal had went over, impaired LV relaxation even earlier than regional wall motion abnormality. And then you also see it in someone who has longstanding hypertension as well as hypertrophic cardiomyopathy, because that's also a form of diastolic dysfunction. So if you compare the old echo and your new echo to the current day, and you have a new diastolic dysfunction, then it's a good idea to actually follow these patients closely. So every time you do zero EKGs, do repeat the echo, because you also want to rule out any ischemic etiology. And then one thing to note too, like Dr. Joffrey had mentioned, in grade 1 diastolic dysfunction, those patients have basically normal LA pressures. What they do have is delayed relaxation. So these patients, so for example, if a patient comes in shortness of breath and you want to rule out an etiology as in terms of ischemia, these patients are the ones that you would do a stress test on. If they have any other grade of diastolic dysfunction, there's no need because you already have the answer. So just keep that in mind. This is also something relatively new, where basically you're looking at the strain of the heart. So what we found is there's so many modalities that go into measuring the left ventricular ejection fraction, but we know that it's not sensitive enough to, right, because it's usually a later finding. So it's not sensitive enough to detect subtle changes in contractility or subclinical myocardial damage, because you can have no regional wall motion abnormalities. You can have the subclinical one where this would actually be very helpful. So some of the challenges that are seen, though, if it's a patient who has baseline LA strain. So basically what they do is they measure the if they have enlarged left atrium to begin with, right? So then you're actually having high LA pressures. So it seems like it's not accurate in those individuals. And then what they found here, so basically what they do is they actually take a look at the LV and they measure the LA, left atrial systolic strain, and measure LA pressure. And then that basically estimate the LA stiffness, right? What Afsa was talking about, like how it has that delayed relaxation. So that's how they distinguish. You have heart failure who has preserved EF from diastolic dysfunction. So by doing so, what they do is they go through something called speckle tracking, where basically it's a form of imaging of the myocardium and more so to see the deformation of the myocardium. So what it does is it's actually characterize as well as quantify the extent of how well the myocardium is contracting. So it's kind of cool. You basically what they do is they some of the newer machines have this where they actually go and color code the walls of the LV. And what it does is it measures the rate of shortening in contraction and then lengthening of the muscle in relaxation and getting the percentage of the length change between the two. So between the shortening and the lengthening over time. And it basically, what it does is it predicts adverse, or is shown to predict adverse outcomes after an MI. And that what they found was that the global longitudinal strain, so you'll see it here, which that they found was the earliest sign to early myocardial damage, and therefore it's the most sensitive. So what they also concluded was that it's also a predictor of how much the infarction is, the total size of the infarction, how patent the coronary artery is, and basically it can predict the outcome of revascularization, and as well as like long-term complications like LV remodeling. So you'll see basically here what they do is each segment it's a little harder to see, but it's basically being mapped out here and they're measuring the strain of it here. And then that's how they come up with the percentages. Pretty cool. All right, so some of the take-home points. We know that echo is very useful, right? We can find out right away. We can use it at bedside. It's an adjunct to everything else, our history, physical, our EKGs when it comes to acute chest pain. We know that diastolic dysfunction is the earliest sign of ischemia, even before regional wall motion abnormality. And then also we learned about the 17 segment model of the distribution of the coronary artery supply. And we also learned a little bit of what the new study is of any subtle changes in the myocardial damage can be detected by strain using speckle tracking.